Okay, all right. So, so today I'm going to talk about the heart sounds. Okay. So heart sounds actually it is something. This is the auscultatory aspects. Okay. This is the auscultatory aspects of our heart. Okay. And if it is the question of auscultations, then obviously this is important. What is this? This is stethoscope. Okay. This is stethoscope. Okay. The signature sign of doctors. Huh? This is what? This is stethoscope. So, an ideal stethoscope having it has some parts. Look at this. An ideal stethoscope. One diaphragm is there. The larger portion of the chest piece. This is called the diaphragm. This is called the diaphragm. Diaphragm of the stethoscope. Diaphragm. Okay. This is called the diaphragm. And this it is called the earpiece. This is called the earpiece. Okay, this is the earpiece, and this is the tube. Ideally, this tube must be 25 centimeter in length. Ideally, okay, and the diameter of the tube, the diameter of the tube. This is the length of the tube, length LENGTH, and the diameter of the tube that must be something 0.325 centimeter. Okay, and the diameter of the diameter the diameter of the diaphragm that must be equals to 4 centimeter ideally. Okay, so they are earpiece. So ideal stethoscope should have oil fitting earpieces and a thick long tube of 25 centimeter length and 0.325 centimeter in diameter and diaphragm of 4 centimeter, and one portion is also there which is called the bell of the stethoscope. Bell means just the opposite sides of, if this is the chest piece in lateral view. This is the, let's imagine this is the chest piece in lateral view. It's something like this. Okay, this is the chest piece in lateral view. Lateral view. This is the lateral view of a stethoscope. Okay, it is something like this. Here is your earpiece. There is another earpiece. Okay. Oh, wow. This is one earpiece and this is another earpiece. Okay. Yeah. And this is called diaphragm. This is called diaphragm. And this portion is called bell. This is called the bell of the stethoscope. This is the bell of the stethoscope. Okay. So bell, the diameter, ideal diameter of the bell that must be 2.5 centimeter. And ideal diameter of the diaphragm 4 centimeter. Ideal length of the stethoscope 25 centimeter, and diameter of the tube that must be diameter of tube that must be 0.325 centimeter. Easy? Is it easy? So actually
Yes,
these
sir.
are the parts of a stethoscope. Okay. So now the diaphragm, generally the diaphragm, this is actually used. The diaphragm is actually used. Diaphragm of stethoscope, it is actually used to hear the high pitched high pitched sounds. Okay, so high pitched sounds are heard by the diaphragm of the stethoscope, and low pitched sound. Low pitch sounds are the heard by the bell of the stethoscope. So heart sounds. So sound must be there is something which is called the some quality of sounds or sound wave. If we are discussing about sound wave, then we all have to talk about the amplitude of the wave, or you can say the intensity of the wave. And uh, this is all of these discussions are from generally 12th standard. We all know about the amplitude, we all know about the intensity, and we all know about the frequency and the pitch. Okay, frequency and the pitch. Okay, generally what, now male voice and female voice. So male voice is what, male voice is low pitched. Female voice is high pitched. Okay, high pitched. Roaring of lion, it is low pitched. And mosquito, this is the song of mosquito, the musical rhythm of mosquito. This is what, this is the low pitched and this is irritating. So I am talking about that pitch. So the diaphragm of the stethoscope is used to generally detect the high pitched sound, and the bell is detect the low pitched sound. Look at the table first. Look at this table. So low pitched sound, low pitched sound. Okay, so low pitched sound, there are which sounds are low pitched. First, that is third hertz sound, third hertz sound, fourth hertz sound. H is for hertz sound. Okay, third hertz sound, fourth hertz sound, and mid diastolic murmur. One murmur, that is mid diastolic murmur. What is murmur? And I will talk everything about the murmur later. But actually, heart sounds and murmur, these things are not synonymous. Okay, this is, there is little difference between sound and murmur. I'll tell you these things in during the discussion of murmur. Okay, so generally the low pitch sound are this, and high pitch sound. Look at this, high pitch sounds. Just for this moment, just for this moment, remember the high pitch sounds which is heard by the high pitch sound which is heard by the diaphragm of the stethoscope are generally fast heart sound S1, that is fast heart sound. Second is the S2, that is second heart sound. And the clicks. What is clicks? What is clicks? Look at this. I'll discuss about the click little later. Then opening snaps, opening snaps. Then the pericardial rubs, or pericardial rubs, knocks, pericardial knocks, or you can say pericardial knocks. And the systolic murmurs, and the early diastolic murmurs. Okay, so during the discussion of murmur, I'll tell you the murmurs and pericardial rubs and pericardial knocks. I'll discuss these things also later with very deep and detail and depth, with very depth and detail. Okay, but for this moment, S1 is 2. I am going to talk about these things elaborately, but just what is a click and what is a snap. Look at this thing first. What is a click and what is a snap? Let's imagine. Let's imagine this is the four chamber of your heart. Okay, four chamber of your heart. Yeah, this is the left. This is the right atrium, right ventricle, left atrium, left ventricle. Easy. This is the schematic diagram. And what is this? This is the from left ventricle, your greater aorta. Aorta is emerging out. Okay. And from right ventricle, your right ventricle, your pulmonary trunk, PT. I am writing pulmonary trunk or pulmonary aorta. Okay. Now, what is a I'm talking about fast heart sound. Okay. First of all, look at this. When what happens? Now, when and here is your mitral valves. Okay. This is the let's imagine this is the mitral valves and this is the tricuspid valves and here is the semilunar valves. Okay. There are semilunar valves. There are semilunar valves. Now, what happens during the ventricular systole means when the ventricles, both left ventricles and right ventricles, they starts contracting. When the both ventricle starts contracting, what happens? There is a tendency of backflow. I am just briefing this thing here. I will discuss everything of S1, S2, and every heart sounds later on. But for this moment, just this is the introductory or the opening statement. During the ventricular systole, what happens? Blood. There is a tendency of the backflow of the blood towards atria. Okay, during the ventricular systole, when the ventricle starts contracting, there is a tendency of the backflow of the blood towards atria. Okay, these valves, that the atrioventricular valves, the valves which those are present in between atrium and ventricle, the atrioventricular valves, that is mitral valve and tricuspid valves, they are they are preventing they are preventing the backflow of the blood. And there is the closer the closer of those bulbs, this is nothing but the closure of those bulbs. So when mitral valve and tricuspid valve closes, closure, the closure of mitral and tricuspid valve produces S1. Briefly, okay, 12th standard understanding. Okay, this is 12th standard understanding that the mitral and tricuspid valve closure produce S1 during ventricular systole. Okay. Next, what happens?
Okay.
Next, what happens? This is the S1. Now, what happens? Second diagram, that is the pulmonary trunk or pulmonary artery, you can say PA, and that is the aorta, greater aorta. Okay, aorta. Now, what happens? Look at this mitral valve and tricuspid valve closes. Then, what happens? The blood which is present inside the ventricle, the blood which is present inside the ventricle, this blood moves towards the aorta. This is also moves towards the pulmonary aorta. So the from blood from the left ventricle moves towards the aorta and from right ventricle moves towards the pulmonary aorta. Okay. So during this process, what happens? For the movement of the blood from left ventricle to aorta and right ventricle to pulmonary aorta, one thing is important, that is the opening of the semilunar valves. Opening of the semilunar valves. So, opening of the semilunar valves is important during the end of the ventricular systole. At the end of the ventricular systole, the opening of the semilunar valves. This is the semilunar valves. This is the semilunar valves. Schematically, the opening of the semilunar valves is important, and this opening of the semilunar valves leads to leads to ejection of blood into aorta as well as into pulmonary artery. The opening of the semilunar valves leads to ejection of the blood into aorta and the pulmonary artery. And in healthy individual, ALTHY, in healthy individual, there is no sound. There is no sound, no audible sound via stethoscope. There is no audible sound in stethoscope, or there is no sound is audible via stethoscope during the opening of during the opening of semi lunar valve. There is no sound. Opening of semilunar valve, there is no sound heard by stethoscope. But if any pathology or abnormality, if any pathology or abnormality is there, if any pathology or abnormality is associated with this semilunar valves like aortic valve and pulmonary valve, then obviously pathology, any pathology to semilunar valve, any pathology to semilunar valve means what? Semilunar valve means your aortic and your pulmonary, aortic valve and pulmonary valve, semilunar valves. If any pathology is associated with this semilunar valve, then their opening, their opening leads to some sounds. Their opening leads to some sounds, and this sounds is called your clicks. This is called your clicks. So what is clicks? Click normally in a healthy individual, normally in healthy individual, there is no sound. There is no sound of opening of those semilunar valves. In normal individuals, there is no sound associated with the opening of the semilunar valves. But if any pathology is associated, if any pathology is associated with those valves, then obviously opening of the valves leads to abnormal sound. This sound, is it normal, sir? No. Is it abnormal? This is abnormal sound, and this abnormal sounds is called clicks. So click, you have to hard this click, we have to hard these clicks with the diaphragm of the stethoscope. Is it easy? Is it easy up to this or not? Is it easy up to this?
Sir.
Is it audible? Am I audible, better? Okay, okay,
Sir.
okay. Easy. Okay. Next, next. This is high pitch sound, low pitch sound. Okay, all right. Next, what is opening snap? Okay. So next is what is opening snap? Yeah, opening snap. This is what something. Look at this. When the blood coming from when the blood coming from atrium to ventricle, when the blood comes from artery to ventricle, what happens? One important thing, that is the opening of the opening of the mitral valve as well as opening of the tricuspid valve is important. Okay, when blood coming from atria to ventricle. So what happens generally, the 70%, generally the 70% of the filling, 70% filling of the ventricle, 70% filling of the what, ventricle, 70% filling of the ventricle, 70% ventricular filling, ventricular filling, it is passive filling. It is passive filling, that means this is filling due to, filling due to gravity. Just blood is present on atrium, and due to gravitational pull, this blood's moving towards the ventricle. Easy? These bloods moving towards the ventricle. But 30% filling, 30% filling of ventricle, this is active filling. This is active filling. 30% filling of ventricle is active filling. That means for 30% filling, last 30% filling of the ventricle, they are active. There is active participation. There is active participation of the atrium. Okay, that means the atrial contraction, the contraction of the atrium, or the systole of the atrium, the systole of the atrium is needed. The systole of the atrium is needed for the last 30% filling of the ventricle. Okay, so the 30% filling of the ventricle, 30% filling of the ventricle by blood, 30%, last 30% filling of the ventricle by blood, it is active filling. And here the contraction of atria, atrium is important, or atrial systole is important. But first 70% filling, there is no necessity of the atrial contractions. Okay, this is passive, and last 30% is active. So now during this process, the opening of these two valves is important. So the opening of mitral and tricuspid valve, the opening of mitral and tricuspid valve is important. And once again, in healthy individuals, in healthy individuals, the opening of these two valves leads to they not produce any sounds. Actually, opening of any valves in healthy individuals, opening of any valves does not produce sounds. But if any pathology is there, if any pathology, if any pathology associated with those valves, any pathology, if any pathology associated with those valves, they leads to opening, opening snaps. Opening snaps means during the opening of mitral, during the opening of mitral and tricuspid valve, there is a sound which is pathological, and this is called snaps. Okay, so this is the basic difference between snaps and the basic difference between clicks. So once again, tell me, what is clicks? Any healthy, 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 any healthy valve of heart during opening, opening does not produce, does not produce any sound. Okay, bhai. So opening of valve does not produce any sound. Easy. Then during closure, if the semilunar valve closes, semilunar valve, semilunar valve means aortic valve and pulmonary valve. If semilunar valve closes, it leads to, it is called, if semilunar valve opens, sorry, I'm extremely sorry, if semilunar valve opens, it leads to clicks. And if Atrioventricular valve means mitral and tricuspid opens, they leads to snaps, and clicks are snaps. These two are pathological sounds. Pathological logical sounds. This is not healthy heart. Is it clear? Am I clear? Hello.
Sir.
Okay,
Hello.
fine, clear.
Sir.
Okay, clear. Okay, nice. So this is the difference between your what now click and snaps. Next. So now next I'm going to talk about the first heart sound. Okay. So in this discussion now I'm going to talk about the first heart sounds. Okay. So there is some need of pages, blank pages. Okay, easy. So let's start. So generally, heart sounds. When we are talking about the heart sounds, there is in general S1, S2, S3, S4, and also other heart sounds are also present. But now I will discuss these things also. But first of all, let's talk about the S1. S1 is the fast heart sound. Okay, S1 is the fast heart sound. So S1 and S2 they are high pitched. S3 and S4 they are low pitched. Okay. So S1 this is the fast heart sound. And first of all, what is the how the S1 is produced? The mechanism behind the production of S1 or fast heart sound. Okay. First of all, when we are talking about the systole, when we are talking about the systole or systole, we are majorly emphasizing the ventricular systole. In normal cardiac cycle, normal cardiac cycle, that means the 72 beats per minute heart rate. Okay, the time of each cycle is generally zero point 0.8 second. Okay, so time of each cycle is generally zero point 0.8 second. Out of this zero point 0.8 second, zero point 0.3 second and zero point 0.5 second. So this zero point 0.3 second, this is what? This is the systole of the ventricle, that is ventricular systole, and zero point 0.5 second time taken for ventricular diastole. Okay, that means contraction of ventricle and relaxation of ventricles. Now during the ventricular systole, so something, let's talk about something, the cardiac cycle. Very few point of cardiac cycle. Very few important point about cardiac cycles. So first of all, look at this. Just a minute. Where is my notes? I forgot to open it. Just a minute. Yeah, look at this. What happens first? Once again, look at this. what happens first in this first diagram, the normally from atria to ventricle, the blood is coming from the atria into the ventricle. The initial 70% is passive filling, and remaining 30% is the active filling. Active filling. That means this active filling means during this stage, the remaining 30% filling of the ventricle, during this stage, the contraction of the atria is important. So the atrial systole, it is due to atrial systole. Okay. Then what happens? Mitral valve, it is already opened and blood rush from this atria to ventricle and
Ventricle.
accumulates in the into the ventricles. And then what happens? Then what happens? The mitral and tricuspid valve both closes. The mitral and tricuspid valve both closes. Closure of the mitral and tricuspid valves. Okay, closure of the mitral and tricuspid valves. When the both valve closes, so the closure of mitral and tricuspid valve M, T. When the ventricle is filled totally, when the ventricle is filled totally with blood, then what happens? Ventricle starts contracting. The ventricle starts contracting. That means the ventricular systole is started. When the ventricular systole is started, the pressure inside the ventricle elevated, starts rising. The pressure inside the ventricle starts rising. The pressure inside the ventricle starts rising. And the pressure rising and rising and rising and rising. When the pressure of the ventricle, it dominates or it is exceeds the arterial pressure, when the pressure of the ventricle dominates or it exceeds the arterial pressure, then what happens? There is a tendency of the flow of the blood from ventricle to atria. Why? Blood or any fluid always flows from high pressure zone to low pressure zone. So when the pressure of the ventricle exceeds the pressure of the atrium, what happens then? There is a tendency of the backflow of the blood. There is a tendency of the backflow of the blood. And now what happens? This valve closes to prevent the backflow. This valve closes to prevent the backflow, prevent the backflow. And this closure of the valve is related to, it is related to, I am not telling that it produces, it is related to, it is related to S1, that is fast heart sound. So the closure of the valve related to fast heart sound. When it closes during the starting, or you can say onset of during the onset of ventricular systole, during the onset of ventricular systole. Just a minute.
Yes, sir.
Okay. Next. Okay. So now in this diagram, look at this. This is the left side of the heart, and this is the left atrium, and this is the left ventricle. Okay. This is the LA and LV, left atrium and left ventricle. Now look at this. What is this? What is this? This is the annulus. This is the annulus of mitral valve. This is the annulus of mitral valves. Mitral valves having annulus, and leaflets, anterior leaflets and posterior leaflets. Okay, let's imagine schematically. This is the annulus of the mitral valve, and there is one anterior leaflets. Okay, this is anterior leaflets, and there is one posterior leaflets. This is the leaflets of the mitral valves. Okay, or you can say that there is two cusps. That is why this is also called bicuspid valves. This is also called bicuspid valves. Okay, there are two leaflets. I think previous was this. This is more smarter. This is one, and this is one. This is called the annulus of the mitral valve. What is this? This is the annulus of mitral valve, and these are the leaflets of mitral valves. Okay. Now what happens? The leaflets of the valves, the leaflets of the valves are attached with the leaflets of the valves are attached with the chordae tendineae, attached with the chordae tendineae, and this chordae tendineae it's attached with the muscle of the ventricle via papillary muscles. Okay, what is this? This is the papillary muscles. This is the ventricular mass. Here is the ventricular mass, and here is the arterial mass. Here is the arterial mass, and here is the ventricular mass, and this is the annulus of the bicuspid valve, or you can say what? Na? This is mitral valve. Okay. Now look at this. There is one leaflet. There is something here is the posterior leaflet, and something here is the anterior leaflet. According to this diagram, etc. I'm not bothering about that. So look at this. Some chordae tendineae are attached. The chordae tendineae are attached with the leaflets, and this chordae tendineae is attached with the ventricular mass with papillary muscles. This is the anatomy. Okay. Now what happens? When ventricle starts contracting, when the ventricle starts contracting, when the ventricle starts contracting, what happens? The ventricular mass starts contracting. That means ventricular systole started. And when the ventricular systole started, this chordae tendineae, this chordae tendineae, they becomes taut. Okay, this chordae tendineae become taut, straightened and taut. Okay, high tension is there.
Sir.
And when this chordae tendineae becomes taut, it prevents it prevents one things. It prevents the bulging of the mitral valve. Let's imagine, look at this diagram, schematic diagram. Let's imagine when the ventricular pressure is starts rising, the ventricular pressure starts rising, and when the ventricular pressure exceeds the arterial pressure, what happens? There is a tendency of bulging out of the atrioventricular valves. The atrioventricular valves, it's trying to bulge out towards the atrial side, and then what happens? Then there may be a chances of leakage of the blood. But this chordae tendineae, actually, this chordae tendineae is prevents these things. Let's imagine this is chordae tendineae, and this is your papillary muscles. This is chordae tendineae, and this is your papillary muscles. And this chordae tendineae becomes taut, and this chordae tendineae backward bending, prevents the backward bending of the atrioventricular valves. Okay, and this tension in chordae tendineae actually causes this. Okay, closure of the valve. Now what happens? When the chordae tendineae tension, chordae tendineae becomes taut, and what happens? The chordae tendineae becomes taut, and a vibration is something. This mitral valve leaflets starts vibrating. This mitral valve leaflets starts vibrating during up and down, up and down, up and down. This mitral valve and tricuspid valve leaflets starts vibrating up and down, up and down. Okay, and the chordae tendineae associated with this, it also starts vibrating. Not only that, the whole ventricular wall also associated with this also starts vibrating. Okay, and Not only that, the blood column which is present in the ventricle, they are also vibrating. Okay, so the valve and the adnexal structures, that means the structures are associated with the valves. In association with valves, the whole system starts vibrating. The whole system starts vibrating. The whole system is vibrating. Okay, so the whole system is vibrating, and this vibration, this is our skin of the chest. This is our skin of the chest. This vibration is transmitted in our inside our thorax, and this vibration is transmitted into the skin. And here is your stethoscope. This is your stethoscope. Okay, this is your stethoscope, and you heard this in your ears. So this is the actual mechanism of the generation of fast heart sound. So actually the fast heart sound is not, the fast heart sound is not the closure of mitral valve and tricuspid valve. Actually, the mitral valve and tricuspid valve closure are associated or related with fast heart sound. But what is actually fast heart sound? Actual fast heart sound is the closure of the valve. Okay, in case of tricuspid valves also, the closure of the valves, there is some, what is happening? The closure of the valves. First of all, the valve bulges out towards this, and that quadritendony taut papillary muscles contracts, and it it pulls back the valves to its own positions. Okay, and this valve starts vibrating up and down, and the quadritendony as well as the papillary muscles as well as the ventricular mass, that means adnexal structures, everything starts vibrating. Okay, everything starts vibrating, and the blood column which is present inside the ventricle, it's also vibrating. The blood column present inside the ventricle is also vibrating, and this vibration of the valve actually is producing what? The fast heart sound, that is S1. That is
This one.
S1. Is
Hi, sir.
it clear? Okay,
Sir,
okay, okay. Now now there are two parts of S1. Okay, S1, that is the fast start sound. There is S1. It is due to the closure of mitral valve. That is M1. M1 mean fast start sound, and also the closure of tricuspid. That is T. So S1 is something written like M1 T1. M1 T1 is, that means the closure of mitral valve as well as the closure of tricuspid valve collectively produces S1. Mitral and tricuspid collectively produces S1. So obviously the S1, there is two component. One is mitral component and another one is tricuspid component. Okay, okay, and the left ventricular mass. Everybody knows that the left ventricular mass, it is three times, the left ventricle is three times more muscular with respect to right ventricle. The left ventricle is three times more muscular with respect to right ventricles. So
hi,
the
sir.
vibration associated with this contraction of the huge mass or massive ventricles, the vibration associated with these massive ventricles, the vibration associated with these massive ventricles
Three
obviously
times.
produces large sound.
Hi, sir.
Obviously produces large sound.
Loud sound.
That's why the M1, it is M1 which is associated with the closure of the mitral valve, and there is the tricuspid valve. Okay, this is a little bit. Now look at this. Yeah, so obviously M1, that should be slightly louder with respect to T1. It is slightly louder with respect to T1. Okay, is it clear? And there is a time gap. Actually, the second heart sound is not like single heart sound. The first heart sound is something written as love, and the second heart sound is loved. Okay, but there is a slight difference between M1 and T1. So let's imagine this is the first heart sound. Okay, this is the first heart sound S1. Okay, then there is second heart sound. This is S2. Then further the first heart sound S1. Actually, should be little. Okay, S1. Okay, in between S1 and S2, this is called ventricular systole, and S2 and S1, this gap is ventricular diastole. I'll tell these things later also. Okay, okay. Next, S1, it is not a single sound.
Yes.
There is M1, T1, and S2 is also not a single sound. There is closure of the aortic valve and closure of the pulmonary valve. Okay, is it clear? But the
Yes,
time
sir.
duration, the time duration between the time duration between closure of M1 and T1 is 20 millisecond. This is very less. This is very less. Actually, it is not 20 millisecond, less than 20 millisecond. It is less than 20 milliseconds. So, first M1 closes, mitral valve closes, and after 20 millisecond, tricuspid valve closes. Okay. So this time gap is very narrow, very little time gap. That's why it is appreciated as a single heart sound by our ears. Okay, it is appreciated as a single heart sound by our ears. Okay, is it clear? So there is a time gap also between M1 and
Yes, sir.
T1, that is 20 millisecond. Actually, less than 20
Millisecond.
millisecond. This is the time gap. Okay, I'll discuss H2 in later, but for this moment, uh, this is the game. Next, fast start sound. Okay, so what happens? There is another concept here. That is the, yeah. So this is the mitral valve zones. This is the actually mitral valves. This is the mitral valves. Look at this. The two leaflets of mitral valves. Okay, this is the two leaflets of mitral valves. The body is smooth, and this is called the coaptation zone or rough zone. This is the coaptation zone. Okay, the coaptation zone of mitral valves. Okay, when the blood starts black backflowing, it's when there is a tendency of backflow of blood. What happens? The chordae tendineae taut, and tautening of the chordae tendineae leads to this, and the mitral valves closes. So this is called the coaptations. This is called the coaptation zone of the mitral valve. Look at this. This is the coaptation zones. This is the coaptation zones where two leaflets are attaching with each other. This is the coaptation zones. Okay. Now what happens? One important thing is the there is a annulus of the mitral valve, and there is two leaflets. There is one important thing, that is annular contraction. Annular contraction. The contraction of the annulus, like this. Contraction of the annulus. Annular contractions. It leads to coaptation of valve leaflets. Valve leaflets. Actually, what happens when the annulus is contracted? When the annulus starts contracting, what happens? These leaflets and these leaflets, they are moving towards each other. Okay, they are moving towards each other, and there is a coaptations. There is a coaptation of those two leaflets, like this. This is the coaptations zone of coaptations. Okay, and next coaptation of the valve leaflets. Nice, coaptation of the valve leaflets. of a bandwidth, cooptation of valve leaflets of a bandwidth of a bandwidth of 3 to 5 millimeter, of a bandwidth of 3 to 5 millimeter. Okay, and then sudden tensing of the sudden tensing of the leaflets produce vibration, and this vibration is nothing but S1. So sudden tensing of the leaflets due to the tension of the papillary muscles, due to the tension of the quadritendonic papillary muscles, and this sudden tensioning of the leaflets leads to a vibration which produces S1. Okay, which produces S1. Look at this. This is also called the coaptation length. Here is the coaptation length. Look at this. This is the coaptations of the leaflets of the mitral valves. And now there is mitral valve is open now. This is open. Okay, and there is the coaptations of the mitral valves. Okay, two leaflets are coapted. Okay, this is the game. This is the game of the this is a game of the what fast heart sound. Okay, this is how the fast heart sound is produced. So fast heart sound is the loud this is obviously loud heart sound, and you have to use your stethoscope, the diaphragm of the stethoscope, to hear the fast heart sound. Okay, so this is about the origin, how the fast heart sound is originated. This is about the fast heart sound is originated. Next, in this next topic, that means tomorrow or day after tomorrow, I'll talk about the intensity of S1. In case of fast heart sound, the most important thing is intensity. When the S1 should be, it will be loud or it will be soft S1. The reason of the loud S1, the reason of the soft S1. This is important. And for S2, the splitting, splitting is important in case of S2. Splitting means already it is splitted A2 P2 aortic, first closure of the aortic valves, then pulmonary valves, already it is splitted. Okay, so the splitting is important in case of S2, but intensity is important in case of S1. I will discuss these things later. Okay, for this moment, this is the uh, funda behind the fast heart sound origin. Now, next day I will talk about the pathology of fast heart sound. Okay, all right.